And one of the procedures they always used to make me do was to do a workup, make them a new set of dentures. And it was interesting that half the patients I made new dentures for said, thank you very much. I don't need implants now. I'm actually quite happy with these. And they're much better than they were before. I really don't think I want implants. I went, okay, maybe a lot of these patients don't always need implants. They just need to have well-fabricated dentures.
FP1, FP2, FP3. Do you know what I'm talking about? No, I'm not talking about filtering face pieces, i.e. FFP3 masks. Like, we're all experts now on FFP2 masks and FFP3 masks, unfortunately, due to the COVID pandemic. But do you know what I mean when in the context of implant restorations, what I mean by FP2 and FP3? Well, I'm embarrassed to say I had zero idea when I came to talking to our guest today, Harpal Chana, who's a consultant, restorative dentist, and the pinnacle of full arch implant prostheses. Like, this guy does some most complex work. The kind of work Harpal Chana does is based on referral work, complex full arch prosthesis work. So it's a great honor to have him on the show today. He's someone who I've looked up to for many years, like all the clinicians that I have on the show. I had a impromptu lunch with him in Pizza Express, actually, just behind his practice in Teddington, when I was absolutely starstruck. I was like 1 year qualified. And back then I knew who he was, I knew what he was about, and I went to a few more of his study clubs in the local area. And he just is a brilliant clinician. What he has to share today is all about the classifications. Like, basically it's implant classifications, and we're gonna delve deeper into what a GDP, what the average GDP ought to know about full arch prosthesis. Like, okay, fine, you may or may not be placing implants, you may or may not be restoring full arch implant dentistry. However, do we owe it to our patients to understand what FP1, FP2, FP3 means, what the surgery might involve, and to basically be able to give our patients more information rather than just take a massive step back and say, you know what, I don't know, speak to the specialist. I don't know, you just speak to the specialist. I think we can do better. So I'm hoping this episode will benefit you as much as it benefited me. Sometimes you have to just be straight up honest about what you do and what you don't know about. So I know a fair bit about occlusal appliances, resin bond bridges, managing tooth wear, occlusal design. What I don't know much about is implants, okay? So this is like my big weakness area because I don't place. But I think, like I said before, I owe it to my patients to learn more. So this is part of my journey, and I hope I'm sharing that journey with you and you will find benefit from it. For those of you who are listening on high quality speakers or headphones, you probably realize that my voice sounds a little bit hoarse at the moment. This is because just recently I was at the Tubules Congress. That's called the Dental Tubules Congress. It's the best dental event of the year. There was Ed McLaren, Marco Veneziani, and some of the great British lecturers that I absolutely adore, the specialists which absolutely inspire me so much. And you guys, so many of the Protrusive were there. It was so great to see you. I'm not gonna begin to name all of you people that I met for the first time and were reunited with for many times over. It genuinely felt like we used to have these events called the BDSA as a student, which is the British Dental Students Association, and they were the best nights out. Like, we'd go to like a dental school maybe in like Manchester, and we'd all meet up, and it'd be the best thing ever, having dental students from every uni around the country. It really had that great positive inclusive vibe that only a Tubules Congress can offer. So save the date in your diary for 6th and 7th of October next year. Location to be confirmed. We're thinking maybe Midlands, so we'll keep you updated on that. But it was so great to see and speak with every one of you. Thanks for saying hi for those of you who listen to the podcast. And it was actually really weird. People coming up to me, dentists coming up to me, you know you are, guys, thank you so much, saying, let's take a selfie. I was like, yeah, cool, let's take a selfie. Or some of you coming up saying, oh, I'm just a massive fangirl or whatever. That was really weird for me, but it was just absolutely amazing. I had such a great time. It was lovely to see every one of you, and I hope that we can continue to meet up in face-to-face events. My next one will be the BACD Pascal Magnier, 12th of November. That's where I'll be next. So if you're there and you listen to the podcast, please do say hello. The protrusive dental pearl I have for you today is non-implant because I can't teach you anything implant related. But what I can teach you or share with you based on what Govinda Birth shared with me many years ago. This is probably like a BARD, British Academy of Aesthetic Dentistry meeting about 3-4 years ago now. And a really cool thing he shared with me about the protocol for placing a crown or placing indirect restorations. He encouraged me to stop booking my patients in for a fit appointment because that puts a lot of pressure on you as a dentist and on your technician, especially when you start doing more complex cases. So what I mean by that is sometimes you may have had it before where you seat the crown on and either the occlusion is way off, or there's an open contact, or there's an aesthetic compromise and the patient's not happy. So in those scenarios, it's like, oh, I'm so sorry, we have to remake this now. Whereas the better way to do it, what Govinda taught me, and I'm happy to share with you, is to tell your patient that, hey, this is not a fit, we're going to do a try-in. So it's a try-in appointment. It's just a change of a name. It really is a fit appointment, but you're framing it as a try-in appointment. And if everything goes well, the aesthetics are good, the fit's good, the contacts are good, and you're happy with the level of work, then you will go on to cement it that day. But if there's anything that you're not happy with, or if anything the patient's not happy with, that's a perfect opportunity to say, okay, this is what we learned from today's try-in. Let me get this corrected for you. And at the next appointment, we will do another try or a fit. So 19 out of 20 times, you'll probably go ahead and fit anyway at that appointment. But it's just the labeling of the appointment, which I quite like. So sometimes I have a tricky case or a complex patient, and I think I will brand it as a try-in. I know some dentists who always brand it as a try-in. It's about the way that the patient perceives that to be, but I think there's merit in using that terminology for your appointments. So I hope that communication gem was useful. Hat tip to Govinda Bhatt for sharing that one with me some years ago. So let's join Harpal Chana and learn all about full arch implant dentistry. Harpal Chana, welcome to the Protrusive Dental Podcast. How are you?
Very well, thank you, Jazz. Very, very kind of you to ask. I'm fine. Hope you're well as well.
Yeah, absolutely brilliant. We just had a little chat before we started recording about how COVID has affected our different worlds, and it's been tough, and we're still while we're recording now, it's still ongoing, and the extreme pressures. But
absolutely,
I think we are now that we're getting vaccinated and stuff. Hopefully, the end is in sight, and we're having a little chat about that. But yeah, health is wealth, as you know, and that's the main mantra. I wanted to do a small introduction for you for those dentists around the world listening, and then I'm going to get you to introduce yourself. So,
sure.
Harpal, we met at a Pizza Express many years ago outside.
I'm not a cheapskate. I would have taken you somewhere else, honestly.
It was geographical convenience. I'm sure if it was Michelin star, you would still would have taken us. It's
absolutely.
Fine.
Absolutely.
So you practice in Teddington,
That's
where you
right.
practice. I always go Teddington. When I go to the Nando's, I always see your practice. And I say, yeah, Harpal works there. So that's your sort of claim to fame for me as well. But you're a well-known restorative consultant. You do a lot of advanced cases. When I think of zygomatic implants, I think of you. Now I don't know much about zygomatic implants, and you can help us a little bit with that. But even more, we're going to dumb it down even more to just fixed or full arch cases for the GDP, right? So the GDPs that aren't doing them or are starting to dabble, to give us some insight so we can better inform our patients. That's the point of today. And I can't think of anyone better than you, who's so vastly experienced in all forms of full arch cases. So tell us, how did you get involved with full arch cases? A little bit about your sort of history as a restorative consultant. How much time do you spend in hospital now versus practice? Give us a flavour of that kind of stuff.
Well, yeah, thank you, Jazz. Well, my experience really is from a general practice perspective. I started life as a general practitioner. I worked in general practice probably a good 4 years, actually, but I was very keen and hungry to learn. I was very much keen on fixed and removable prosthodontics. That's sort of one area I decided to sort of focus on, really. Had a little dabble in the early days with orthodontics, and although I thought that was my chosen career pathway, I soon learned actually, due to relapse problems, that it just didn't tickle my fancy. So it was a big awakening, and you're finding your path in your early careers as to what you like. And I always enjoyed fixed and removable prosthodontics, but there was always something about it I didn't quite understand, and I was very keen to do the MSc in fixed prosthodontics at the Eastman. So actually a year or so after qualifying, I started to apply to guys in the Eastman. And no surprises, I didn't get in straight away because the competition was quite high. I hadn't had fellowship, and my background was very much general practice. But I plodded on and I continued applying, and the third time round I managed to get in. And thanks very much to great mentors, actually. At that time, I was mentored by people like Martin Hussain, Cash Ubi as well. Cash, I'm sure you know of as well, a great guy. And Martin Kelleher, actually, who was my local consultant at King's. And I used to take a lot of cases over to him just to discuss how to manage them, because it was like a great enigma to me. I didn't know how to do a full mouth reconstruction. I saw a lot of wear patients, and I wasn't quite sure how to manage these cases. So a great rapport.
Harpal, I just want to interject now, actually. You've actually passed the baton along yourself. Like you mentioned, Martin Kelleher, Cash Ubi, people who inspired you and whatnot. But some episodes ago, I had Richard Porter on.
Oh, yes.
And he mentioned you as the mentor that that you inspired. So it's great that you were inspired, but it's also wonderful to know that you have also mentored and inspired other great clinicians. So it's a chain. You receive and you give. It's fantastic. Yeah.
Absolutely. I think what Martin's always taught me is actually education is one of those things that it's a never-ending sort of curve of learning, basically. And half the education is actually getting people around you to discuss things in an open fashion so that you can clarify things in your own mind. And I think Martin was great at that, and he still is. I know he's retired, but I still have contact with him, and he's still quite inspirational on that front. I'm glad other people are taking on board what I've learned basically over the years, and the baton gets passed on from generation to generation from that sense. But going back to the Eastman, I finished my course there, and it's one of those things. I finished, and I thought I still have all these questions. You've learned a huge amount, but it actually just opens more, pages for you that you don't really understand or don't really get clear in your mind at the end of it. And so the hunger was there to get more and more information. And thankfully, actually, I managed to carry on at the Eastman for about 6 to 9 months as a registrar. So I was able to complete more cases. And thankfully, an opportunity opened up as a specialist registrar at that time in restorative. And I thought, well, yeah, why not? Let's give it a go. It's not something I intended to do. But thankfully, it was the right pathway for me, I think. And it just opened a whole avenue of further doors to explore and improve my education and understanding of fixed and removable prostho. So I did the SPR in restorative dentistry, and I credited over 20 years ago now. And it was, again, as soon as I got appointed as a consultant in restorative dentistry, one of my links used to be Queen Mary's Roehampton, which is now closed, so you probably never heard of it. Which is not a million miles away from Kingston, but it used to be quite an epicenter actually for Max Fax prosthodontics. Since the Second World War, a lot of research was done there, and that's when I first came across Peter Blenkinsop, who was one of the Max Fax consultants, and Professor Brunnemark, who used to come over roughly once a month and help do these rather large reconstructions. And that was my first ever experience.
And you had exposure directly to Prof. Brunnemark showing you?
Yeah. We were in theatres with him and operating. He was a very open guy. I mean, you were half the time mesmerised by his presence. But he was actually a very down-to-earth clinician as well. Although he was not a dentist, actually, or even a Max Fax surgeon, he could relate things very, very easily to the Max Fax field and dental field. And I never quite understood that. I never had the chance to really ask him either. Why did he explore a dental route? It's for an orthopaedic surgeon, you would have thought someone would have been thinking more along his specialty lines. But it just shows you how great a man he was. He was very interested in dentoalveolar defects, and hence the relationship with Peter Blenkinsop, and we had an honorary fellowship appointed for him as well, so that he could actually work in the department. And he brought a great amount of experience and wealth to our department. So much so I actually got the plaque and I put it on my wall actually at the practice when we sadly closed down, because like most great things in the NHS, things move on, and the services got pushed elsewhere basically, and we ended up fragmenting some of that service in the end. So that's really where my interest in implant reconstruction sort of came from, mostly cancer patients, patients who had large maxillofacial defects, missing half their face basically, and working with some great prosthodontists. Martin Kelleher was there. He was one of the first people who just threw me in at the deep end. Just, there you go, get on with it. And There was a sharp learning curve, basically, at that period of time. And Xirogiannis at that time...
And what percentage of your work now is full arch, complex implant reconstruction, and what percentage of it is the more initial stages of your full mouth traditional reconstructions?
Yeah, at the practice, I spend roughly sort of 60-70% of my time at Elmfield House, where I take on a lot of referrals, basically, on patients who have a miserable time with dentures or they present with a lot of tooth wear. I don't actually have a lot of clinical time available now for true restorative dentistry, I have to say. Hence why I know you asked me initially whether I talk about gold onlays, because that was my baby 20 odd years ago. But actually I do very little of it now, and so much so that actually I've got great people like Harjot and Manish at the practice who are also at the Eastman, and they're pretty much at the forefront. So if a patient comes in with a lot of tooth wear and need a full mouth reconstruction, I still assess the patient. I still see the patients jointly with Harj and Manish, and we jointly plan it together so that I don't lose touch and that sort of thing. But by and large, a lot of that work on teeth anyway is managed by the prosthodontist at the practice. But my sort of interest is when they're missing teeth. And having a debate, we have lots of debates at times, when is it the end of the road for those patients with failing teeth? What is a terminal dentition? And that's quite a difficult, question to answer sometimes. And hence why we do like having joint consultations, because I may have my own views, Manish may have his, and as well as Harj. And we sometimes see the patient jointly just to work out what is savable and what needs to go.
I don't think that happens enough in private practice, because I can see it happening more multidisciplinary meetings in a hospital-based setting. But in a private setting, I don't think it happens enough, and I think we need more of that. It'd be great to do that. It's just, you know how it is, the way the business works, the way the diaries work, it can be difficult to arrange that. So I know I'm going off tangent, but I'd just love to know a couple of minutes on how do you actually zone everything so that you have these opportunities to have multidisciplinary sort of a meeting about a patient?
Well, as you say, it's extremely difficult. Everyone's part-time. You have to make time available for it, to be honest. And the interesting thing is that even with referring dentists, I do try and encourage them to come along. I'll try and fit around them to some degree. For example, we get quite a few patients referred from Nick Chard, who's practiced in Staines. And he always wants to be there at the consultation. And I say, absolutely right. It's essential that you are, because often you're doing the prosthodontic work in tandem with us. So, it is difficult at times, and we have to sort of throw around our diaries, and, the patient has to accommodate to us as well. But we normally make it work. It may have to work in an evening sometime, and we're there till 8, 9 o'clock to see a patient jointly. But that time is so valuable, because you can iron out so many problems, actually, and we're all on the same page, and that we all know what each other's roles are, and ultimately the patient gets, I think, a better service by and large. So they will often accommodate that sort of wish. If there are patients that need to be seen at a particular time, that's the only time available. If I can't make myself available to do it for whatever reason, or I'm doing an NHS clinic, then we just have to impress upon the patient that actually if they want the best outcome, they have to work around us to some degree. And more often than not, they will accommodate to our desires. But really it's about getting the right outcome.
Especially with the nature of the complex work you're doing, I guess these patients are a different beast to your normal patient who doesn't have as many problems. The scale of their problems are not as big, and the type of treatment will be a bit more simple. I think these patients that you see have seen many dentists, many specialists in the past, and they need a major reconstruction. Henceforth, the importance of having that team approach rises more. Now, Harpal, you mentioned the terminal dentition. Now, I was actually going to ask you this as the last question, but I think it will flow so nicely. If you don't mind me asking you this. When I was a couple of years qualified, I went to an implant-based lecture in Sheffield, And I was absolutely shocked. And at that time, because of my lack of experience, I was disgusted by what I saw, because what I saw was photos of patients, and when, you know, their full face photos when they smiled, they had teeth, their own teeth. And I was, oh, brilliant, they've got their own teeth. Okay, in my head, I'm treatment planning, you know, a bridge here, a bit of periodontal stabilization, obviously in the reverse order, maybe a partial denture here, and the patient will be happy, or a couple of implants. But then what I saw was a full clearance and then a beautiful full arch reconstruction of implants. And at the time, I just couldn't fathom it. I didn't understand, right? It didn't make sense to me. But later, it made more and more sense that actually, and you can correct me if I'm wrong and elaborate on this, is that if you have someone who's got severe periodontal bone loss, and if you just let that continue and continue and continue, you'll get to a point where implants may not be a possible option anymore. So I can see why it's such a tough decision to deem someone as a terminal dentition and decide that actually we need to start fresh by extracting all the teeth. So there was a huge shock to me. So can you expand a little bit more about that for dentists to help them decide at what point is someone terminal that they should be considering a reconstruction like that?
Well, you know, Jazz, that's a really good question, but it's actually a really difficult answer at times as well, because I can get 10 people in a room and I can show them radiographs and put a clinical scenario together, and you can ask 10 dentists, including specialist periodontists, and you can ask them, you know, what stage is this patient terminal, and you'll get 10 different answers, because no one really fully understands and grasps what a true terminal dentition is. For a periodontist, for example, they might be hanging on for sort of 3 to 4 millimeters of bone. And then there may be others who, in fact, I had an interesting patient only last week, actually, who came to me for a third opinion. And he was missing his posterior premolars and molars in the maxilla. And he had 6 remaining upper anterior teeth, which had about 20 to 30% horizontal bone loss, actually. And he'd been around the houses, and he'd said, you know, I've come to the conclusion I've got very little bone in the posterior maxilla. I've been told I just don't have enough to consider implants. And I've been told that sinus lifts are possible, but I might have to wait a year or 2 before I can have the final reconstruction. I've decided I really want my front 6 teeth out, and I'd like to have this all-on-4 type of reconstruction. And I have to say, this is a patient telling me that he felt his teeth were terminal. They were quite rigid, they were quite firm. And I said, well, I don't agree with you. Whoever's told you that it's certainly an option. But, there's mileage in those teeth. There's a possibility that those front teeth could give you another 20 years of service with good maintenance. Your problem is at the back, and we can fix that by other means. But the criteria for terminal dentition is so variable, and I certainly have had joint consultations with periodontists who have got very upset when I've said, the patient's not happy, the teeth are loose, they've got 70% attachment loss, there's not much bone remaining back in the maxilla now, this is probably the time to deal with it. And sadly, my suggestion may be to take some of those teeth out now, and while they still have bone, to consider implants. Before it gets more complicated. It's never, they can always consider it.
Well, Harpal, like with anything, I thought you'd give me a magic number. Well, I know, I didn't think that. I was secretly hoping you'd say, okay, the rule is if there's 75% bone loss and you've got X number of teeth, the formula suggests that you should remove all the teeth and head for implants. It's never, ever in dentistry ever going to be as simple as that. And I think you've just summarized it well there. That actually, it's a gray area, and this is where you need multiple inputs to decide, along with the patient's values as well, about what determines a terminal dentition. So I don't envy you at all in these decisions you have to make, such tough decisions.
Yeah, it can be tough, and sometimes we have real arguments with it, which is actually why I like having joint consultations, because I'd like to argue my case. It's nice to hear from other people's opinions. Harj is coming along the scene and training quite nicely, and he's sort of exposed to some of this at times, and he asks very simple questions as well. He says, well, why are you taking them out, and why is somebody else, the periodontist, wanting to save them? And I said, a lot of it is subjective experience of how we've dealt with things in the past. And there is no magic cure for a lot of these patients. If the patient may have terminal periodontitis, they may well end up with, peri-implantitis in the future. And that's something else to bear in mind. It's not as if the problem stops there. So, it's really understanding the patient's perspective and what their goals and objectives are. And sometimes if they're a complete tangent to yourself, it can be a real challenge. I certainly remember presenting a case years ago, which actually Simon Chard, I'm sure you know, used to work at our practice, and we sort of jointly saw together, and she had quite advanced periodontal disease. Lots of consultation. We must have had 3 or 4 consultations with her, and we decided at the end of the day she had a very gummy smile, high lip line, short upper strap lip, 70-80% bone loss, teeth that are loose, ex-smoker, and she wanted to avoid wearing dentures. And we took a very radical decision. We took everything out and put implants in, and gave her what I considered a fantastic result. And so did she. She thought it was a brilliant result. And I presented this at a local BDA lecture group, and I have to say I was quite shocked the amount of attacks I got from periodontists. Periodontists said, I could have kept those teeth going for another 5-10 years. You just needed to section some of those teeth and keep some of the roots out the bone, and you could have splintered the others. And I said, sure, you absolutely could have. And you wouldn't have been wrong. But a lot of this is discussion and debate, and ultimately the patient would still have a poor aesthetic result with a high lip line. And once you start getting recession in the horrible black triangle spaces, if a patient can live with that, I said there's no harm in going down that avenue. But once you show patients photographs of what their teeth are going to look like, once you've had an extensive course of periodontal treatment and all the horrible gummy black triangle spaces, I said they may not want that. So it's really part of your consent process. And if the patient says, yeah, I don't mind, I'd rather keep my teeth going for as long as possible. I can accept the fact that they won't be pretty, but they're my own. And that's absolutely fine as well. There's no hard and fast rules about it. It's about tailoring the treatment plan to what your patient's wishes and desire, once they fully understand all the options. And I think that's the crucial take-home point, really, for general dentists, is actually understanding all those options yourself and laying it on the table for the patient. Saying, well, these are all the various treatment plans that we could consider. There are pros and cons of each. You may not be the right person to do the full arch reconstruction. That's why we think mentoring is a good thing, so that your patients can still have a course of treatment. And we work jointly with the dentist as well, so that they understand the reconstruction element and often do it jointly with us.
Harpal, I'm just imagining how thick your patient letters are. Like they're probably like each patient gets a book, a volume of all the options, explanations.
I try not to make it too thick, to be honest, because like most things, I probably write fewer notes than most dentists, surprisingly. And the reason is I want to give it to succinct points. I try to just highlight really what the discussions were with the patient and what avenues we discussed. And my general rule is try not to make it more than 2 sides of A4, because most patients can't take more than that in. And if you provide them with a dossier, which I've certainly seen, and I know some of my colleagues do that as well, the ability of the patient to retain a lot of that information, although it might be very comprehensive, it might confuse them so much that actually they don't really understand the nuances of the treatment plan at all, because you've given too much information overload, basically. So, and it's the same if you ever get a letter from me from the NHS. My rule there is 1 side of A4 paper. If you can say it all on 1 side of A4, then you may miss out some of the salient features. And if somebody wants to elaborate and want more information, I don't have a problem in going back and giving them further information, as long as you've got detailed notes for it. But really, I try to give a summary sort of option. If somebody else is carrying out a treatment plan, of course, and you're giving them advice, clearly you need to give the dentist a lot more information at that point. But when it comes to patients and writing to them, I try not to overload them with information. Actually, I'd rather give them a few pointers and actually get them back in and discuss again with them, because that time is so valuable, talking to them face to face and understanding their concerns and fears and what their desires are. Because, as I say, if you write them a huge letter, I guarantee you'll end up probably scaring the life out of them and probably not seeing them again. So it's always better to have a good follow-up appointment, write to them with Yeah, in my view, no more than 2 A4 sides of paper, and get them back in and discuss it again to make sure that they understand what the options are and why they want to choose what they want to choose.
Brilliant. I'm now going to, if you don't mind, I'm going to go back onto the implant theme because we're going on some tangents here.
Yeah, no
and
problem.
it does very valuable tangents, I have to say. So we talked about the grey area of deciding if someone's a terminal dentition or not. I think you cover that beautifully. I think the last part of when you summarize that was just phenomenal about the way you pitch it to patients, and that's fantastic. We then talked about, obviously, I joked about the letters to patients, but now I want to bring it back to a dentist patient. So if you're a GDP and you have an dentist patient in front of you and they're struggling with their denture, and then you want to say, okay, I can refer you to someone who might be able to help, or maybe you're the dentist who can place some implants. What are the usual options that people can explore in terms of, there are fixed implant reconstructions, there are removable, there are hybrid. Can you just break it down for the GDP, the newly qualified dentist who doesn't really know where to begin with classification and what's available?
Yeah, that's a good question. Actually, before you even go down the implant avenue, I think the most important part, as you say, is they have unsuccessful dentures, is try to understand why they're unsuccessful. If a patient comes in with a whole bag of dentures and says, I've been trying 20 different dentists, etc., and I can't seem to find one that works, but this set and that set mixed together seem to be the best, those usually are big warning signs that perhaps those patients are going to struggle. But equally, I recall when I was, a registrar, I used to have to work up cases for full arch reconstructions with Professor Roger Watson. I don't know if you recall him at King's, and David Davis. And one of the procedures they always used to make me do was to do a workup, make them a new set of dentures. And it was interesting that half the patients I made new dentures for said, thank you very much, I don't need implants now. I'm actually quite happy with these. And they're much better than they were before. I really don't think I want implants. I went, okay, maybe a lot of these patients don't always need implants. They just need to have well-fabricated dentures. And making good full dentures is, it can be extremely challenging as well. But a good prosthodontist should be able to make them. And a good general dentist should be able to make them if they spend time and effort. And that's always the first port of call, I would always say, because if a patient is struggling, you need to work out whether those concerns are really genuine. Are there actually technical problems in the denture? Is the patient actually just one of those that can't tolerate dentures? And that's what you're trying to ascertain in the early stages. And you'll be surprised how many patients actually would be satisfied with just that alone. I certainly was, and these were patients on a waiting list for implants, and they were getting it free, so it was no financial incentive for them not to say no at a particular point. So it was certainly an eye-opener. And it was a very valuable exercise as well, because it taught you how to plan for the implants as well. Space creation and half the technical and restorative problems you could pick up actually in the wax try-in stage of how much intraocclusal room that you have. So all of the basic stuff which you think probably not that important for implants is actually crucial for implants, because it sets the footing for when you go down the implant avenue, what type of treatment avenues you may be considering for a patient. So there's one very good article by Carl Misch, who sadly passed away, on implant reconstruction design from FP1 to RP5. Now that's, you may come across, there are some dentists who may not have come across it, and it's very much to do with whether you give a patient a fixed reconstruction or a removable. And an FP1, so FP means fixed prostheses usually, they're graded into 1, 2 and 3, with FP1 just replacing the white part, I should say, of a patient's dentition, so the crown part. So if there hasn't been a huge amount of volume loss and periodontal disease or trauma and all those things, then that patient may be suitable for what we call an FP1 type of design. But if there's been a bit of recession or there's some bone loss, if you have this thing called an FP2, which is also a slightly more complicated sort of a gradation, so it's slightly more recession. So you're replacing not just the white part of the crown, you'd be possibly replacing a small part of the root form as well. If the patient's lip line is quite low, they don't show it too much, then it probably doesn't matter if those teeth are slightly clinically longer in their appearance because the patient never shows it. And then you have the FP3, which is actually replacing not just the white part of the tooth, but the pink stuff as well. So you can understand there's been quite a lot of volumetric bone loss in these cases. So you are trying to replace both hard and soft tissues of the bone structure. Now, that then leads on to the removable RP4 and RP5. Now, RP4 is actually going to an implant reconstruction, which is purely supported by implants, but it's still removable. So you may say have 4 implants to hold a prosthesis in place. So it's replacing all of the white and a lot of the red stuff, the pink stuff, but it's anchored by 4 implants and is supported by implants. And then you've got the RP5 in his list, which is basically same sort of volume loss, but it's maybe supported by 2 implants or 1 implant for that matter, and it's partly mucosa supported and it's partly implant supported.
If you don't mind me asking, Harpal, because I learned so much from that because I don't do implants myself. Sometimes you never get exposed to because I've seen it all banded about on social media in papers and lectures. Oh yes, I did an FP3 or whatever, and you sort of think but I've never done my due diligence to actually go through it. So I learned so much, and I know people listening and watching would have learned a lot. Just basically, you've just gone through from FP1 to RP5, and it was crystal clear. I just remembered I was a DCT at Guy's Hostel, and I used to work with restorative consultants. Sarah Tabiat-Poor, who you might know, she taught me once that, and then some of the consultants taught me once that what I was making for my patients at a time, they had 2 implants in the lower canine region. We had put some locator abutments and the housings inside the dentures. But strictly speaking, she told me that this is not an implant-supported overdenture, and I should use the term implant-retained overdenture because, and is that just semantics, or is there something in that? Is there a difference between something that's implant-retained and implant-supported, or can you mix and match them?
Yeah, that's a good word. The terminology is crucial to this and understanding the detail because you're quite right, or she's quite right, I should say, in the sense that the vertical load in that, the implants, if you just got 2 implants taking the full load, those 2 implants are going to take a pretty hefty occlusal, battering basically. And usually you just want to stop the denture falling out. A lot of patients' problems is they can't keep the denture in place. Many years ago, we were talking over 20 years ago, the McGill conference suggested 2 implants, as you suggested, was a brilliant way of sorting out patients' lower denture problems. In fact, even 1 implant is satisfactory to improve denture, not so much support, resistance to it falling out. And often that was the biggest problem for patients, is keeping the dentures in place. So technically you're right, and that's the distinction between the RP4 and the RP5. Because an RP4 has implants, and although you've got a removable prosthesis, the implants are taking all the load. The RP5, the implants are there just to assist, so I call those implant-assisted dentures. They stop the denture falling out. But the occlusal loads are still taken, by and large, by the supporting alveolar tissues, basically, the soft tissues and the bone around it. Now that creates other problems, as you know, because over time, that patient will get continued resorption in those regions, and therefore maintenance of those cases is much greater. You often have to reline those cases to avoid overloading the implants in the long term. But no, you're quite right, there is a distinction, and understanding that distinction is quite important, because if you expect those 2 implants to take all the occlusal load and they still to be there many years later, it can certainly open your eyes in terms of functional problems and implant complications. In fact, we've had a case recently at Kingston Hospital, an oncology patient whose mouth opening is very, very restricted. And I've just about managed to get 2 implants at a very acute angle in the mandible because his mouth opening is so poor. And I thought, well, we're trying to extend the prosthesis as far as possible. So an RP5 design with 2 locators. And it was a sharp, rude awakening when he's fractured well, one of the implants is fractured and the other one actually was explanted by the denture. He literally came out with it, and I thought, blimey.
Wow.
So maybe these situations, now we're having to redo it now with further ridge reduction, space problems, because these patients often post-oncology have very limited mouth opening and have had to do quite a lot of ridge reduction just to create space for the prostheses. And to try and extend the prostheses now so it can actually take a bit more support from the alveolar tissues. Those cases can be quite challenging as well.
And well, since you touched on the number of implants, the next question I wanted to ask, and it just leads beautifully to that, is when I used to see patients, I used to work in Oxford, and my principal was an implant placing dentist, and he was happy to do full arch cases. But when I saw my own patient who had the quote unquote terminal dentition or was struggling with an unsuccessful denture and they needed some help, I'd have to always meet with my principal dentist at lunchtime. It's like, here's the photos. I don't know what to quote because I don't know how many implants this patient needs. And every time I take a patient photos, you get a different answer. And obviously, everyone knows, every dentist, every student dentist probably knows the famous AO4, all-on-4, right? But is that the rule of thumb, that 4 implants solves everything? I assume not. But tell me, how do you even begin to fathom how many implants are going to be needed for a case? And why is it sometimes vary between 4, 6, 10? Is it purely financial, or is it much more anatomical?
Yeah, well, so there are lots of reasons. There are multiple factors, to be honest. And I went from my early training, I'd be trying to put as many implants in as possible. And it's interesting how you almost come full circle. As you know, I've worked very closely with all-on-4 centres as well. And you have to be very careful with the number of implants versus long-term maintenance and complications. For example, as I said to you, you may have a patient who's got an edentulous mandible and just is miserable, can't cope with the dentures, and they're okay with a full upper denture. Surprisingly, even a single implant in the mandible in the midline to help secure that denture is more than enough. Most people would probably put 2 and consider it an RP4 because it's much easier putting 2 in and getting some support both sides. But if you've got an 80-year-old who is struggling to eat satisfactorily, a single implant to help secure a lower denture is more than adequate, believe it or not. You may choose to put 2, but you sometimes find they can't always get the prostheses out with 2 because their manual skills and their dexterity may not be as good and the retention may be so good that you have to then deactivate one and then go back to one. So it's horses for courses. You have to put so many factors in: the patient's wishes, desires. The all-on-4 really sort of took off, I would say, probably about 20 years ago as the sort of base standard for trying to provide a cost-effective way of giving patients fixed reconstructions. Now, there are certain problems, and we've certainly seen them in our own clinic when only 4 are used, especially in some patients who are susceptible to perio or their quality of bone is not so good. And it's interesting, having done that for a number of years, and we've managed to sort of repair and try to remedy some of the problems with patients with all-on-4. I've sort of gone back in and put extra implants in now in the maxilla. So I've taken a slightly more dimmer view now of the maxilla. If we're going for a fixed reconstruction, which is often what patients referred to me for, that I'm very much of the view that perhaps if I can get 6 in and get a good AP spread, then I'll probably give myself a better insurance policy in the future for any potential complications. Part of the problem with 4...
Can you define AP spread for some of the younger dentists who may not know what that means?
Yes, AP is really the anterior-posterior spread and the cantilever design. And I've certainly been to lectures and I've heard people who are very well versed in this that they don't worry so much about the extent of the cantilever, especially in the upper jaw. Actually, I do. I get very paranoid about the extent of cantilevers because we know the longer the cantilever, it's basic physics from A-level physics on levers, basically. The longer the lever, the greater the force you can generate. And no surprises if you've got a large cantilever, especially in the maxilla, you're going to get more prosthetic and, in my view, surgical complications of bone loss around the implants. Perhaps the peri-implantitis isn't always peri-implantitis. It may be overload of the implants. The difficulty is managing those cases in the long term, especially 5-10 years down the road. The patient's invested quite a lot of time and money, and you put a lot of effort into it as well. So that if you do get complications, how do you deal with it? And hence why I'm sort of gone back partly to some degree of what I used to do in the old days. And I try to over-engineer. I don't see a problem with over-engineering, because at the end of the day, it depends on what kind of service and maintenance program you've got for that patient. So ironically, we did a case just Saturday. George Xirogiannis, my periodontist, and myself did a upper and lower fixed arch reconstruction for a patient with a complete dental clearance. And the mandible went perfectly well. We managed to get 6 pretty much straight implants in the mandible, great AP spread up to the first, the second premolar stroke, small cantilever to replace the molars where there was insufficient bone. But the upper proved exceptionally difficult. I managed to get 4 good implants in the intercanine region, but the posterior implants were an absolute nightmare. They really were. I struggled to get pterygoids in. The pterygoid bone was really quite hopeless. Using all the tricks, and it nearly took me 3 hours to try and get the additional implants in those regions. But in the end, we ended up with 8 implants in the upper jaw, 2 of which were buried, just to wait for the bone to repair, because there were another 2 which weren't so great. Their stability, primary stability, wasn't that great. So you still walked out with fixed teeth the same day. So I didn't plan to put 8 implants in the upper jaw. We were planning just to put maybe 4/6 with possibility of 2 zygomatic implants or pterygoids. But life doesn't always work out like that. So you often have to go in with one expectation, and you start struggling a little bit with zygomatics. The mouth opening wasn't as great as I thought. I couldn't quite get the angles to get the zygomatics in. I was hoping and praying that the pterygoids would go in, and they proved to be absolutely, very well. Yeah, they weren't as good as I thought. So you often have to think outside the box, and certainly George and I were going, well, now what? We've got 4 good ones at the front, but they're only as far as the canine region. I'm not going to do a huge cantilever because the AP spread now on this is so large. I've got potentially 3 pontics cantilevered. You're asking for trouble. You need something further back. And sometimes you have to compromise. So I managed to get additional ones in with a little bit of a compromise.
Some people might be listening right now, Harpal, and I remember the first time I came across pterygoid and zygomatic implants. When you're a young dentist or you're a student and you're thinking implants, and you're looking at implants in the more traditional areas that you'd place them, and then when you first get exposed to you can put implants in these really long things in zygomatic arch areas or your pterygoids. It blows your mind as a young dentist when you're first getting exposed to this kind of stuff. So some people may have been listening to you saying that and thinking, wait, what a pterygoid? And some people don't even know how to spell pterygoid. So it's just how it is. So it's very fascinating. But is there any evidence pointing to, because what you've basically alluded to is it depends on your level of experience, Harpal. It depends on your successes in the past as a clinician for anything you do in dentistry, the team that you work in, your training, about what kind of solutions you can offer your patients. And some dentists do full arches, may not be able to extend to zygomatics, for example.
Sure.
But is there any evidence for quality of life studies, and that certain either fixed versus removal, or a number of implants, or the AP spread? How much research do we have about the quality of life so that we can, as clinicians, inform our decisions based on that?
Well, that's an excellent question, Jazz, and the answer is actually there are lots of quality of life studies available in the dental literature on dental implants, but none of them, or very few of them, really deal with number of implants per se. They often are just looking at a qualitative sort of factor. How does the patient get on? Patient-orientated outcomes, etc. And there isn't that sort of study where you can evaluate quality of life with the number of implants, so to speak. There are some comparing fixed versus removable, and there's quite a lot of studies comparing quality of life with, say, just a complete denture versus an implant, or RP4/5 versus an FP1, 2, 3. And the studies are equivocal to some degree. We know most of them seem to agree that most patients, if you've made a well-constructed full denture and they're still struggling with it, that any form of an implant prosthesis, whether it be removable or fixed, will improve the outcome compared with a removable denture. That goes probably without saying from most studies. The question really is, I don't know how people have evaluated outcome for the full dentures. Have they actually made new dentures for those patients like I used to have to at King's? So it begs certain questions there as well. Those studies are not completely foolproof from that perspective. But with regards to fixed and removable, yeah, you can find some studies. There's certainly been studies from 20 years ago with, off the top of my head, Saltzman did studies 20 years ago in University of Bern comparing fixed versus removable. And they found actually pretty equivocal outcomes from a patient perspective when you're looking at quality of life factors. Now things have moved on a little bit now. You've got more assessments now. The new quality of life guided by the WHO. There's a lot more detail in terms of questions that these patients have to answer. And these are very subjective questions a lot of the time. They're sort of often patient-led, which is not a bad thing. But if we want more science behind it, you have to do more of the mechanical studies and look at forces, etc. And we know if you measure forces on patients, certainly if you look at a patient, if they had their natural dentition with 100% worth of occlusal force, if someone's given a fixed reconstruction, they're almost 90% there to what the patient had previously. With implant retained dentures, it's a little bit variable. It's sort of between 50 and 70% in general, compared with dentures, which can be 0 to 20 to 30%, depending on how well the patient can tolerate these things. But certainly from an outcome perspective and quality of life, it is actually very difficult to dissect whether fixed versus removable is better. And that's often where patients' input come into, and obviously their budget as well, because at the end of the day, we are dictated to some degree by what our patients can afford. Hence why it's very important to discuss all these avenues. You can explain to patients the advantages and pros and cons of an implant retained denture versus a fixed prosthesis, and also ease of maintenance and hygiene. Those are the sort of factors patients really do need to understand, and depending on their age as well. I mean, I had a GP who was only in his late 50s last week, who had very little residual bone. His dentist has been monitoring and maintaining his teeth for the last 20 years, and they're pretty terminal actually. They're quite loose and they're about to come out. And we discussed all these options with him, and I said, you're still relatively young. What would you like to have at the end of the day? Dentures are removable, they are cleansable, they're easy to remove and keep clean, but they clearly have some coverage of the palate. And having something removable for this doctor who's still practicing and still communicating with his patients, he said, that's not for me. I don't want anything removable. And also there's a psychosomatic sort of benefit for these patients, because they think removable is still not part of them. It's still a sort of, a inverted commas, a second-hand type of problem to fix, basically, compared with something fixed, which is like my own. And that's important to understand from patients' perspectives as well. But it is very difficult.
I really like that example you gave with the GP. I think it really makes it more tangible. And some dentists listen to this. That explanation that you give to patients, that's really valuable, actually.
Yeah, and I think you have to be honest with them. And just, equally, I've got a patient at the other age extreme who I'm dealing with at the moment, who's had an FP3 fixed reconstruction with quite severe bone loss. She's already had zygomatic implants placed elsewhere, and she's struggling to keep them clean. Her manual dexterity is not as good as perhaps they thought it was going to be. And there are a few other complications I won't go into, which has necessitated her having further treatment with us. But actually, I've convinced her to have something removable. And I said, I think you'd be better off actually with an RP4, primarily because actually you can take it out and clean it, and you can look after things. And we've done the first preliminary step for her. And she's over the moon already. She says, why wasn't this offered to me at the beginning? I'm actually really upset. So it does make you think when patients say that, well, maybe we should spend a little more time with them at the beginning explaining these avenues. And I think, unfortunately, in her situation, she'd had very little discussion with all the treatment avenues that she could have explored in the early days. And she's, in her 80s as well, so it's not as if she's in the younger age group. And we know what tends to happen as we get older. Our skills, our manual skills go down. So they may have had great intentions of giving her something which they considered superior, but maybe didn't factor what the patient variable sort of part of the equation is. And that's always a learning point for me as well, just to say, well, would I have done the same? Would I have gone straight to a fixed reconstruction? Whereas, and probably, the sexy factor of having something fixed is the driving factor, because you think, I'm giving somebody something which is close to what nature gave them at the beginning. But actually, we've got to think beyond that. We've got to understand there's a patient at the end of it, and how they're going to look after it. Does it give them all they need? Does it give them all the function, the phonetics, and more importantly, the physiological support of their lips and the ability to maintain? I think that part is actually very difficult to answer, the maintenance part, which we're not so good at explaining to patients. We assume naturally.
That is brilliant. That is fantastic.
How are they going to look after these things? Are they going to get underneath these prostheses? We've actually just been asked, one of, I don't know if you know Pynadath George, who is part of an implant. And George, Pynadath and I have been talking to each other about running a course at Elmfield House later this year, which we're just in the final state, in the process of setting up, of trying to explain these differences as well to dentists and actually how to service and maintain them. So part of the lecture course is not just us saying this is how we put the implants in and how we restore them, but we've got a hygienist and George, our periodontist, on board to say, well, look, these are the problems you may encounter. How do you look after these patients? How are patients expected to clean around them? And I think that's perhaps not told enough, if that makes sense, because that's the long-term game. That's about keeping things going for the next 10, 15 plus years with hopefully very few complications.
Brilliant. I just want to, just in the interest of time, I'm going to ask you one more question. Sure. This is a bit more dentist-specific focus in terms of training pathways, because you mentioned about in the course and educating dentists that you're taking part in with the Pynadath George as well. So it flows nicely to ask you, with implants, when implant education, implant courses are being taught to young dentists for the first time, so dentists learning how to place their first implant, and the advice we're taught is, start with a lower molar, maybe an upper premolar, away from sinus, good bone, the low lip line patient, low aesthetic expectations as your first case, and that's what we're taught. But then I was once speaking to Pynadath George actually a few years ago on the phone. This was before I moved to Singapore. I was asking about, at the time I was considering getting an implants and stuff, and he was asking me, okay, what kind of implants do you want to do? Do you want to do implants, to replace the odd missing tooth, or you want to do full arches? I was like, gosh, I don't know. Shouldn't I start with one? And he was like, you know what? They're completely different kettle of fish. So is there a case for dentists who perhaps are passionate about dentures and those big changes that you give to someone from going no teeth to having lots of teeth and really improving their lives that way, rather than someone who sees a more general population with more teeth? For that dentist, perhaps to skip straight to learning full arch, or do you think no, every dentist who's learning implants is better suited to learning how to restore the single tooth in a bounded saddle area, and then develop on to full arches? Or is there a case for someone to go straight to full arches and learn the basics of that?
Yeah, they are totally different skill sets, I have to be honest. But like most things, in the early stages of one's career, I think, and I certainly have, taught dentists around me in this sort of fashion by getting them to restore a lot more of the simple cases first. I think once you understand prosthodontics, the implant surgery becomes much more straightforward afterwards, because it's prosthodontically led. If you don't understand the prosthetics, and I think that's where a lot of complications arise, is because actually there's no forethought to where you're going to end up. Well, work backwards. So if you can understand where the outcome's supposed to be, then the implant should naturally sort of follow on from the prosthetic part of the training. So a lot of the dentists who certainly work around with me, I don't let them go wild and start putting implants in straight away, because I've seen the harm and the damage it can do for patients, because they just want to get numbers in. They think they're going to get their confidence by putting lots and lots of them in. And all you tend to do is create lots and lots of problems and don't necessarily understand how to fix them. So my view is actually learn how to restore. Once you've restored a few and got your grasp and understanding the space and occlusion, then move on to putting the implants in. And that's the natural progression. And Harj is at that point at the moment. He's missed out a lot of the stages at the moment with regards to what I used to do. We used to have to work on models and drill a hole in a stone model and work out the prosthetic shape before we even. And now we've got all this clever digital stuff. We've just invested in the X Guide, and he did his first X Guide implant on Saturday. And that's the next sort of progression. Really, is to put implants in bounded situations, get a good outcome, understand what gives you a good outcome, basically. And I certainly wouldn't suggest jumping into fixed full arch reconstructions, because often there are so many nuances of learning which you miss along the way with single teeth, that actually you can adapt to fixed arch reconstructions later on. And it might take you a few years. I don't expect somebody to rush into full arch reconstructions from day one and be an expert within 5 years. I've always said, go and learn how to make dentures first, because once you understand how to make full dentures, actually everything else becomes a lot more straightforward. So from the natural progression perspective, I would say always start simple, build up experience on simple cases first, put implants, and I totally agree, put implants in the lower sort of 4, 5, 6 region, as long as you've got acres of bone. Avoid sinus lifts and all that, because if you make mistakes, and that can really put you off. And I've certainly seen patients or dentists who said, I put an implant in and did this sinus, it all went pear-shaped, the implant got infected, the patient ended up with oral-antral communication, I got sued, all sorts of things. And you went, okay, maybe that wasn't a great way to start. Or perhaps they didn't have the right mentoring at that time, and I think that's crucial. So I'm very cautious, and I've certainly, we've run zygomatic courses, and I'm very cautious on those as well. I certainly have had surgeons who've come out after doing a phantom head and said, this looks really straightforward, I'm ready to do my first case next week. And I did have that a few years ago, actually. I was quite shocked when I said, well, actually, we might make it look easy on this hands-on course, but there's lots of technical bits which you don't realise until the day of surgery. And he didn't listen to me. He phoned me up Monday morning and said, I'm about to put this zygomatic implant in. Can I just run through it with you over the phone? And I went, I have to say, I was pretty shocked. I said, I'm really sorry. I can't help you any further. I did say to you, you need a mentor. You mustn't put this implant in without guidance and supervision, because if you mess up, the consequences are quite severe. And I take no responsibility for things going wrong. So, yeah, I think it's horses for course. We often have overconfidence in ourselves because you learn something, you're eager to get on with it. But you don't understand the hiccups and the trips that are along the way that you're going to encounter because you're not experienced enough. And that's where mentoring, I think, is crucial. So your boss is absolutely right. You may come up with different answers for a different number of implants because each case is slightly different. The volume of bone is slightly different. This patient may have acres of bone, and you might say, well, I could put 6 to 8 implants in, versus the standard all-on-4. So each case is different, and you do need a little bit of guidance for it. And there's no cast iron, solution to a lot of these patients. You can often adapt techniques as you go along, and I treat my zygomatic and pterygoid cases exactly the same way. They still need the workup at the beginning. You've got to work out where the final tooth position should be. And those are quite challenging, even when you are putting zygomatic and pterygoid implants in to get the right outcome. But if you do your basics and you do your groundwork, then as you gain more and more experience, you'll get more and more confident in doing things. And then you move on naturally to progression-wise. You probably would want to do sinus lifts, etc. Get your experience in sinus lifts. And zygomatics, and pterygoids are the ultimate. It's not something, even although a lot of dentists I've trained over the years and surgeons, including Max Fax, not everyone gets it. And they're not easy to do. But the most important thing, which we do try and get them to understand, is not about the surgery, it's about the outcome. It's the prosthetic outcome. It's just trying to get that patient the right superstructure to fulfill their needs, whether it's removable or fixed. That's down to you. And we'll all have our debates about whether it's fixed or removable. And I presented a case a few years ago in Italy, actually, to a professor and showed him pre-op studies. And I asked a group in the audience what they would do in this case. And nearly all of them, understandably said, it looks like an RP4 to us. I can understand a lot of volume loss, patient been edentulous for 20 odd years, severe bone atrophy of the maxilla. And I said, yeah, that's certainly an option. That's probably what the patient, would benefit from. But that's not what she wanted. She didn't want something removable. Her psychological aspects was she wanted something fixed, even though there was severe bone loss. And I managed to show how we managed to do a fixed reconstruction with zygomatic implants. And she got basically what she desired, but it was really still planning it and understanding the prosthetic stage. So even, at the other extreme, you can get professors who are very... the professor I presented this to was quite actually horrified. We put zygomatic implants in for this patient. I said, but it fulfilled the patient's needs. She got the outcome that she wanted. I understand perhaps a removable option might have been feasible for her and certainly easier to clean. But I had to deal with the psychological aspects of this patient, and she was miserable with dentures. And for her, even anything removable wasn't right for her. So those are the other factors. We have to work within our own skill set, I have to say. And thankfully, I'm blessed with a good team around me. They're the ones who make us look good at the end of the day and can give us the outcomes that we want. You need really good, excellent technical support to do these things. And thankfully, as I said, we've got Harj and Manish, who are great prosthodontists as well. So they're always teaching me things. I never too old to learn, as they say, and you forget certain things at certain stages, and you go, yeah, I forgot that. Yeah, that's a good idea. Yeah, that's a great solution for the patient. But it's really about being open, having an open discussion with the patient as well, and being frank with them. And we certainly have no problems laying it on the table, telling them all the pros and cons, so that they can make a decision at the end of the day. And they may choose, one pathway over the other.
Amazing. And I think what I've gathered here is that every time you present something to a group of specialists or dentists, Harpal, you got to have thick skin. So I know you must have very thick skin. Amount of controversy you must get, amount of attacks, amount of debates, and I'm sure you love it. And then you're great. I can tell you're great at it. And a massive respect to you for what you do. But you have to have thick skin because, as you say, there's so many. I mean, there's grey areas in all dentistry. But from having this chat with you today, implants is a whole different field in terms of grey areas and lots of strong opinions and subspeciality. Like an oral surgeon might see something completely different to a periodontist, might see something completely different to a prosthodontist,
Absolutely.
right? And then you have those sort of arguments. So I'm going to let you have the mic in a moment to just wrap up, but one thing I want to remind you is that if you could send me some links for any dentists who want to learn more about your programs, about zygomatics, about the course later on, I want to stick down the website before I get bombarded with messages. And also any closing comments for dentists who listened all the way to the end, and we appreciate that so much.
No, really. I think the most important part is just go over treatment planning, discuss with your patient in detail, really take a detailed history from your patient, what their goals and desires are. That's so key to the equation. I think you miss so much sometimes if you don't listen. Martin Keller always used to tell me this at the beginning, and one thing I do try and listen is just zip up at the beginning. Ask the patient why they're there and just keep your mouth shut and listen to what they have to say and write it down. That's so important because you learn so much about what the patient wants and their expectations. And ultimately, just to spend time with them to explain that you understand their problem. So you may sometimes at the end of your consultation just say, right, so just to summarise, I think you've said you really do not like dentures or you don't mind dentures. You just want to have an improvement in quality of life. It may well be that a fixed solution or removable solution is suitable for either of those cases. The workup, in my opinion, is often the same. CT scans, getting them back and doing diagnostic setups. See the patient multiple times, don't rush into it. And I think that's the other problem you sometimes see when patients are travelling and trying to get treatment done quickly. Sometimes you miss out on those salient questions that the patient doesn't fully understand. Certainly we've seen that when patients have gone for dental tourism and they've come back and their expectations have never been met. There's actually probably no one's listened to what their real desires are or spent time explaining things to them and what the limitations of those treatment avenues are. And ultimately, if you haven't got the skills, there are plenty of people out there who will help you. They're great mentors. We're only just one amongst many different clinics throughout the United Kingdom who can help you. So, I always say to dentists, pick up the phone, ping us an email. We'll have a chat. Sometimes I'll have a discussion with them over WhatsApp and just look at the scans and look at the photographs and say, yeah, this is possible. Give them an outline of likely sort of treatment plans just based on their assessments, and then before you've even seen the patient. And then I often strongly encourage a joint consultation if the patient is happy to come for a consultation with the dentist. That really, I think, is crucial. Firstly, the patient really appreciates it, that the dentist is spending the time, and it's part of their learning experience, because they may not have, as you say, have ever come across zygomatic implants or pterygoid. They don't often know what to explain to their patients, and part of my role is explaining that to the dentist as well, so that their patients are well informed as to the treatment options. So keep.
Harpal, when these dentists come and come to these consultations with you, do you take them to Pizza Express or Nando's afterwards? I really need to know.
At the moment, nowhere. They have to bring their own sandwiches at this particular moment due to COVID restrictions. But we're not averse to having a Pizza Express, I have to be honest. In fact, there's a lovely Italian place around the corner from us, and occasionally we have a very nice Italian meal. I love the social part of it as well, actually, because it's a great way of meeting new people and new minds. And I think the future is always the people around you to some degree, and the youth coming up who have got lots of questions and, make challenges on you, make you think things in a different way. So, no, I'm always for that. I'm very much open. We have an open sort of arrangement, and, we have no problems. There's no wrong or right way. We like to discuss things openly with patients as well as the referring dentist, and iron out all the sort of pros and cons, and then usually the patient chooses the right treatment option. And more importantly, if they've never seen anything like that before, they usually go, wow, I didn't know you could do that. I didn't know my patients could have that. And I think that's always a great reward as well, because those patients, they thank you. They love the dentist as well. They've changed their life often, actually, in those situations. And they really can be true life changers. So, by all means, just remember there are patients out there, and it's important to, give them all the treatment options. Even if you don't know about them yourself, there are plenty of people who can advise and guide you, and at least do joint treatment.
And I'm hoping this little chat today would have helped a lot of people. I guarantee you, Harpal, to you, the language of FP1, RP4, that sort of stuff is like second nature. To a lot of dentists, it's not. No. And I think they would learn even just from that, the summary and the wonderful things that the way you explain to patients, including that GP. I think today's episode is full of lots of communication gems, but also you highlighted the importance of having a support network near you, including mentors like yourself who you can pick up the phone. And I love the fact that you said that. Look, WhatsApp, despite all the doom and gloom, I keep saying there's never been a better time to be a dentist who's hungry for knowledge. There's never been a better time in your life. You can connect to anyone, anywhere in the world with a click of a button, WhatsApp, social media, respecting privacy and confidentiality, but to gain knowledge and advice. So that's wonderful. And I thank you so much for giving your time from your very busy schedule to make this episode. I really appreciate it.
Thank you for your time as well. It's great to meet you.
There we have it. Harpal Chana, everyone. I hope you found that useful. I hope you were making notes. It's kind of one of those episodes where you have to go back and maybe make notes. But hey, don't worry if you didn't, because I've got an infographic for you. So if you want a nice little summary, hit the @Protrusive Dental Instagram, and I'll put a little infographic on there. Also on the protrusive.co.uk website. And some big announcements coming very soon, including, so I know many of you will listen all the way to the end, but many of you will just, switch off at this point because it's me blabbering on. However, if you get to listen to this bit, a little secret for you. The secret is that the Protrusive app is coming out very soon. And on there, I hope to make it a little home for all the different infographics, PDFs, references that I share. So it'll be an easy place for you to catch that up. Anyway, let's keep that a secret for now. And I'll catch you in the next episode, guys. Thanks so much for listening.